Hi, Jeff. Thanks very much.
All right, is that working?
It is. Do you want to share your screen and we'll
Yeah, let's see.
beautiful.
Okay, let me see now. Are you seeing the slide or the presenter view?
We see the slide, but it looks like there's presenter view. There's slides down below. It would be fine, but you can go to
Um,
slideshow.
yeah, there you go.
Oh, beautiful. Um,
Excellent.
thanks very much for doing this, and I hope it's okay. We are going to record it. And look at that ballpark. Well, we're not there this October, are we? It's too
None of
bad.
us. No.
That's too bad. But Dr. Bruce initially graduated from University of Virginia, actually, and then went to Rutgers for medical school, and actually was on staff at the NIH and the medical service for a little while, and then wised up and went to his neurosurgery residency at Columbia, where he's been ever since, and really become the voice of neuro-oncology at Columbia, a thought leader in the country and actually internationally. And he's the vice chair at Columbia, as well as the director of the Bartoli Brain Tumor Research Lab, and co-director of the Tumor Center. And he's well known for the work he's done, and going to talk to us today. And he's been, for the residents and fellows, physician scientist who has been NIH funded for many years. So after this, I'm sure he'd be happy to communicate or collaborate or anything. But he is going to talk to us about gliomas, and has been worked for a long time on immunotherapy with gliomas. So Jeff, thanks very much for doing this, and please proceed.
Thank you. It's my pleasure. Chris has been a great friend for many years. I'm a great admirer of his work and what he's done with the program there. So it's really a delight to be here today to talk about what we've been working on. The picture on the right is the Neurological Institute where I've been. Was built over 100 years ago and is the first hospital for neurological disease in the country. And the picture on the left is the old Yankee Stadium, Highlanders Ballpark. That's right where the Neurological Institute used to be. So Highlanders Ballpark was the original Yankee Stadium before they were able to lure Babe Ruth from Boston and the house that Ruth built in the Bronx. So a little sports history for you. These are my disclosures. As of this date, as of now, I've benefited. I've had no financial benefit for any of this work, but do have some conflicts of interest, as you see. Okay, glioblastoma. What do we know about glioblastoma? Essentially, it's a localized disease. 90% of these tumors occur right up where they were originally resected, and metastases are rare. So, as neurosurgeons, what do we do? We're neurosurgeons. We do a maximal safe resection. So I'm not sure. We've done a lot of work over the years with both 5-ALA and fluorescein. Here's typical 5-ALA. The tumors light up. Here's fluorescein, another adjunct for removing tumors. So removing glioblastoma has never been easier. And in fact, it's a little bit paint by numbers now. You can get maximal safe resection with these fluoroscopic compounds without much difficulty. And I think the literature really supports the fact that I think there's enough supporting literature to support the fact that a maximal safe resection is really the role of neurosurgery in glioblastoma. But glioblastoma is not really a surgical disease, right? You can go back over 100 years ago where Walter Dandy actually was performing hemispherectomies for glioma, and even that didn't move the needle. So you can do maximal resection to the tune of a hemicraniectomy, and you're still not going to make an impact on this disease. And Why is that? Why can't tumors be removed? Here you have the normal brain and you add a tumor to it, you remove the tumor, you're always going to be left with that little bit of residue. And that residue is the basis for tumor recurrence. And that tumor recurrence presents a challenge. These tumors are invasive, but they're also heterogeneous. So if you have a strategy that's just targeting one aspect of the tumor, you're going to be woefully inadequate in making any kind of a significant impact. Right now, the status quo treatment is radiation plus Temodar, and even with that, the average survival is probably in the order of 15 months. So you still have to address that residual tumor, but the current standard of care leaves a lot to be desired. And chemotherapy for brain tumors, there is some evidence for clinical efficacy. Obviously, temozolomide makes a difference, and there are lots of drugs that are very effective in vitro or in preclinical studies. So what is it? Do we just need better chemotherapy, or do we need better targets? There's been an explosion in the last several decades of molecular biology and only RNA and DNA sequencing. So to the point where we can get a very extensive molecular signature on any tumor relatively quickly, relatively cheaply. The earliest cancer gene atlas that came out, the first, glioblastoma was one of the first tumors that was characterized genomically with the cancer atlas. But even with all of this information, all of this analysis for glioblastoma, really no molecular targeted therapy has been effective in any GBM clinical trial to date. And why is that? Why are these therapies not effective? Well, the problem is not the drugs. The problem is drug delivery. We have the blood-brain barrier, which is limiting the amount of drugs that get into the brain. And if you try to overcome the blood-brain barrier with just giving higher concentrations of your drug systemically, eventually you're going to have toxicity. So there's a real ceiling on how much chemotherapy you can actually give systemically, in either intravenously or oral form. So remembering that what we say about GBM is that it's essentially a localized disease. And if you look at this, MRI T2 scan here, you see that there you have the tumor, and you see this high signal T2, which is surrounding the tumor, and you know that that's essentially cerebral edema that is associated with malignant tumors, and it's basically fluid or water that's in the interstitial space. The brain tumor, the glioblastoma, secretes vascular permeability factor, causes leakiness of the blood vessels, and you get cerebral edema, which is just essentially interstitial water. But if you look at that volume, that T2 volume, that begins to approximate the volume that you'd ideally like to deliver your drug to. That's the area where the tumor is invading the brain. And if you can safely deliver a high concentration of drug to that volume, you're likely to make an impact on the tumor itself. And so that is the basis for our investigations into this drug delivery system called convection enhanced delivery. You may have heard of it. It's really been around for 25, 30 years. When I was at the NIH in the early 1980s, Ed Oldfield was my mentor. He's a brilliant scientist, great neurosurgeon. And this was really his idea. It's sort of a counterintuitive idea. But, the brain at some level is like a sponge. You have all of these cells, but between the cells, you have a fair amount of extracellular space, or where fluid can actually flow at micro infusion levels. So convection enhanced delivery is just a simple concept where you take a catheter and implant it into the tumor or into the surrounding brain. You connect it to a microinfusion pump, and you pump the drug directly into the tissue. Now, if you infuse at too high a rate, the drug's simply going to squirt up around the catheter. It's not going to penetrate the tumor or the brain tissue. So you have to use very slow microinfusion rates at the rate of several drops an hour, a couple hundred microliters an hour. And then the drug distributes by bulk flow rather than by diffusion. So bulk flow is a way for the fluid to flow interstitially around the cells, and it's different than methods of diffusion. And with this methodology, you get higher, more uniform concentrations of drug, and the rate and volume determine the tissue concentration. So if you increase the flow rate, you can get a wider volume of distribution. And because you're on this side of the blood-brain barrier, the drug characteristics are not important, whether it's a large, bulky molecule or whether it's a charged molecule, things that would prevent it from crossing the blood-brain barrier if it was delivered systemically. They don't matter when you're dealing with convection-enhanced delivery. And so just to stop for a minute and compare the kinetics of diffusion versus bulk flow. Diffusion is how most drugs distribute in the body. If you give drugs systemically, or even if you give a gliadel wafer, the drug will begin to diffuse along a concentration gradient. So it goes from a high concentration to a low concentration gradient. And that here you can see is very inefficient. So as you go at a distance from whatever your source is, you need a very high concentration, and that in a very short distance, the drug concentration drops significantly. So that's probably the problem with gliadel wafers is that you have the drug is there, and as the wafer dissolves, you only get a few millimeters before you get a very rapid drop off in the drug concentration. Convection enhanced delivery relies on bulk flow. And so bulk flow, you can see the concentration stays fairly uniform until you get far enough away from the catheter tip where the pressure gradient starts to fall, and then you get your drop off, and then the drug actually distributes more by diffusion once again. And the benefit of this is it's independent of the drug's molecular weight. You get a fairly homogeneous concentration, and you get a very large volume of distribution. So we looked at a number of drugs in the laboratory with animal models. This is going back many years ago, and when we first started doing this, over 10 years ago. And the ideal drugs for this are drugs that are cytotoxic to the tumor without being toxic to the brain. And you also prefer a drug with a long half-life. And interestingly, since you're on the other side of the blood-brain barrier, it's probably just better that the drug doesn't even cross the blood-brain barrier because it'll stay into the brain. And we tested a number of drugs, and pretty much most drugs will work better with convection-enhanced delivery. Most drugs are effective in our preclinical models. But we found that a drug called topotecan, which is a topoisomerase inhibitor, worked best. And topotecan is a drug that's used for patients with lung cancer. It was tried in patients with glioblastoma, with systemic delivery, and wasn't really effective because there was a lot of systemic toxicity. But when we used it in our animal models with our glioma animal models, we found that it was very effective in killing the tumors safely and extending survival. So we devised a clinical trial where we brought these patients into the operating room. We placed a catheter. The catheter comes out of the head. It's connected to tubing, and you can see this patient here. You can see that pole there has the microinfusion pump on it. So while she's walking the halls or watching television, the drug is slowly infusing directly into the brain tissue, giving very high concentrations of the drug. And so we did a phase 1 clinical trial where with phase 1 trial, we started a very low dose, and for every 3 patients that tolerate the drug, the next 3 patients get a higher dose until we see signs of toxicity. So we did a phase 1 trial with, ended up with 16 patients, and we were able to show that topotecan has significant anti-tumor activity at concentrations that are non-toxic. So when we got to the highest drug levels, there was some toxicity. We backed off a little bit, but the drug levels that were safe were very effective at affecting the tumor. Here you can see one particular patient. There's this is a patient with a recurrent these were all recurrent glioblastoma. So keep in mind, when glioblastoma grows back, you probably have about a 3 to 4 month average survival. And in this patient, this was actually a physics professor at Princeton. Here you can see the tumor at the time of treatment. After 6 months, you can see the tumor is still there, but has gradually decreased in size. And by a year later, it's nearly disappeared. His tumor ultimately grew back after a year and a half, and he died shortly thereafter. But this is sort of good radiographic evidence of a pretty effective therapy. So the problem with this is that if you're relying on a bedside pump like this, you can give the treatment for maybe up to 7 days. We chose 4 days, but you're limited by how long you can treat these patients because you have this external catheter and you have to start worrying about infection. So you're limited to a single dose for 4 to 7 days. Here are our overall treatment response. This was phase 1 study, so it really wasn't powered to show survival, but just show you this anecdotally to show that that we had essentially a 69% response rate. And believe it or not, out of this group of 16, we had 3 patients that survived 3 years or more, and we actually still have 1 patient who's still alive 18 years later, believe it or not. So what are the conclusions from this trial? I think it shows that topotecan has significant anti-tumor activity at levels that are not toxic. We also did quality of life studies and showed basically that this was extremely well tolerated. Patients don't even know that the drug's being infused, so their quality of life is good. They don't get all of the side effects of systemic chemotherapy. And in this trial, the patients were carefully selected. We chose patients with relatively small localized tumors at recurrence, and so these are not the typical recurrent glioblastomas, but we really wanted proof of principle. And our limitation is a single 4-day treatment. So in our mouse models, though, what we also looked at is what happens if you increase the length of treatment. And not surprisingly, the longer you give the treatment, the more effective it is on survival. So if you compare a 1-day treatment to a 7-day, there's a significant survival advantage. And that just makes sense because we know that chemotherapies like topotecan and anti-proliferative chemotherapies are going to be effective when they're given a longer period of time, because at any given moment, only a certain percentage of tumor cells are in the S phase of their cell cycle where they're vulnerable. So you need to give your drug over a long enough period of time to cover as many cycles as possible. And so looking at this, we realized that a single infusion for 4 to 7 days is not going to be sufficient. So we came up with this concept of a implantable pump by taking a simple Medtronic Synchromed pump that's used for delivering pain medication into the spinal column. And we just repurposed it to see if we could use it for convection. And there was actually a trial from over 25 years ago in England where they did something very similar to this with Parkinson's disease. But anyway, we took a pig model. We just using a pig. Pigs are very good because their brains are fairly large and they're easy to work with, much easier than, say, a primate. And we just did some initial studies where we infused gadolinium. We just take regular gadolinium, put it in the pump, and infuse the pump. And here you could see the volume of distribution with the gadolinium. So the advantage of this infusion is that you can infuse gadolinium and actually see in real time what your volume of distribution is. And you can see we're infusing almost the entire hemisphere of the pig brain with our pump. And with that, you can see that there are, a number of advantages from having an implanted pump. So we just used commercialized sources just because from an FDA point of view, rather than have a de novo system, using a pump that's already approved for something else is the easiest way to go. And we, by having an implanted pump, we avoid the infection risk that you get with an external pump, and we can facilitate chronic use. Once the pump is implanted, you can give the drug continuously for as long as you want. And these reservoirs, these Medtronic reservoirs, have you can see they have this little diaphragm, so they can, when they're in the abdomen, they can be percutaneously emptied and filled with a needle and syringe, so you can replenish the drug or empty the pump just with a needle and syringe. And these pumps also have wireless technology, so you can alter the flow rate wirelessly. We used a simple, flexible, thin bore catheter. We just used a pediatric spinal drain kit and used the catheter from that. It's worked fine. There's some ways to improve the design of that to avoid backflow, but for the most part, it worked pretty well. We could place these catheters stereotactically, and if you infuse with gadolinium, you can look at the volume of distribution. And everything about this suggests that it could be useful in an outpatient setting once the pump is implanted. So with our preliminary data in the pig, we were able to get FDA approval for a pilot study doing this in patients. And here you can see schematically the pump is implanted in the abdomen. We tunnel the tubing under the skin and then have the catheter stereotactically implanted in the brain. And the drug is in the pump there. Again, you can percutaneously refill the pump. Here it is in the abdomen. Just get a needle and syringe. And here you can see a typical tumor. And we had a unique trial design. So what we just wanted to show that this was safe and feasible. So our plan was to only have the pump in place for a month. We could, there's no limit. You could leave it in for 6 months or forever, but we figured let's have a nice finite limit of a month. And our plan was at the end of the month after the treatment to then resect the tumor and remove the pump. So that's strategically meant that here's a typical tumor. At the end of the month, we were going to remove the tumor and some surrounding tissue. So we actually placed the catheter, in this case, just behind the tumor, because we wanted to infuse the invaded brain here with drug and the tumor as well. So the idea is to sort of treat this area here and then resect everything else. And excuse me, here are the results. There's a study that we published this last year. We had 5 patients with recurrent glioblastoma. We did a schematic where we would turn the pump on for 2 days, and then turn it off for 5 days, and we did that for 4 treatments. So over the course of a month, they had 4 2-day treatments. The tumor was resected at the conclusion of the treatment. And because we were placing the catheter and pump surgically, we did stereotactic biopsies before the treatment and then after the treatment. So when we first were placing the pump and the catheter, we did multiple biopsies, stereotactic biopsies in the tumor and in the surrounding brain. And then at the end of the month, after the treatments, we took the pump and catheter out, and we did another series of stereotactic biopsies. So this gave us a very valuable resource, and that is we have tissue from before and after treatment, and that was sort of unprecedented. I don't know of any other clinical trials where you actually have tissue before and after. And here is sort of what this looks like. We did MRI scans, and here's the gadolinium. Gadolinium, significantly underestimates the volume of distribution, but it gives you a rough estimate. What we showed is that after about 48 hours, the volume of distribution reaches a maximum, and then it sort of equilibrates. So given the flow rates, infusion rates, 48 hours, we reach a maximal level of distribution. And we also did some PET scanning and other imaging as for non-invasive ways to monitor our drug distribution. And then we had this tissue for before and after that we could look at. So we did sort of standard immunohistostaining, and we were also able to do RNA isolation and do RNA sequencing and genomic analysis. And we also analyzed drug levels. We had a system for measuring drug levels, so we could actually measure at certain distances from our catheter what our drug levels were. And here you can see, again, schematically, here is the tumor. You can see the volume, approximate volume of distribution, again, underestimating the true volume. And here you can see, this is a patient. She gave her permission for this photograph, but she's a real estate agent, and she's in our experimental GCRC, working and selling houses while she's getting her drug infusion. So extremely well tolerated. And here's sort of the tissue analysis. And what we're able to show is with the immunohistochemistry, we looked at certain markers. So SOX2 is a measure of neurons. And essentially what we showed is that neurons were unaffected by the treatment. So we're not damaging normal brain tissue. Ki-67, which is a measurement of tumor proliferation, was dramatically reduced after treatment. And then CD68, which is an inflammatory marker, showed that there was an increased inflammatory profile. We're actually very interested in this, and and what this means. We don't know whether it's a good inflammatory, an anti-tumor inflammatory infiltrate, or whether it's actually an immunosuppressive infiltrate. So we're doing some additional studies on that. And then we're able to do RNA sequencing and come up with a gene sequencing array that actually showed that enabled us to characterize the effect on different tumor types. So we could look at what's happening to the different tumor cells in the brain, and we're actually able to show that the tumor was effective at killing the tumor cells, and it also revealed that there was a specific tumor type cell that was these quiescent tumor cells that were non-proliferative, that were resistant to the treatment, and they weren't proliferating, but they were sort of an obvious suspicion for being the types of cells that will grow back later on. So identifying these quiescent astrocytic-like tumor cells helped us identify the tumor cells that are likely responsible for recurrence. And so we also were able to measure the drug levels. and we had detectable topotecan levels at greater than a micromolar. So micromolar, as you probably know, is extremely high level of drug. Most drugs are effective at 10 to 100 nanomolar levels. So this was extremely high drug levels that were present up to 6.5 centimeters from the catheter tip. So if you look at the center of the catheter tip, 6 centimeters away, you're getting micromolar levels of drug. So this, this circle approximates the sort of volume of distribution you can achieve with super high. I mean, these drug levels are 1,000-fold greater than anything you could possibly achieve with systemic delivery. And so what we showed is that these implantable pumps, they're safe in humans, and that neurons are unaffected, tumor cells are wiped out. There's an increase in inflammatory cells, and there was this residual enrichment of non-proliferating mesenchymal astrocyte-like glioma cells that are likely responsible for tumor recurrence. We also showed that by infusing with gadolinium, we can monitor the volume of drug distribution. And by measuring drug levels, we show that we got very good levels of drug at significant distances from the catheter tip. And by biopsying before and after, we can really are able to analyze different measures of resistance and recurrence. And once again, these are carefully selected patients. So want to emphasize it's just a pilot study for proof of principle. So we took this study, we published it. It actually got some interesting press. I don't know if you know about the Daily Mail is like the New York Post newspaper in Europe there. So it carried this story about this. I mean, we were very happy, very impressed. And then the Daily Mail has all these letters to the editor, and so we're able to see how people could respond to this very exciting, groundbreaking work that we did. And these are like some of the comments. That's all well and good, but how do I get a doctor's appointment? I appreciate that, but we all die. Better that we learn how to best prepare for what comes next. The last thing they want to do is cure it. Too much money being made by cancer, so I doubt that this will come to fruition. Bottom line, it didn't work. The medication did not cure the patients, and all 5 patients died within 12 months. They probably would have lived longer without the treatment. Just another example of the medical industrial complex exploiting people for profit, not delivering any cures. They tortured their experimental subjects as if they were lab animals and charged up huge medical bills. So these very interesting comments were able to bring us down to earth on our work. So where are we now? What are the impediments to curing glioblastoma with convection-enhanced delivery? Well, we've already identified, as I said, some resistant cell populations. We still may not be able to reach every tumor cell, but we come pretty close to reaching nearly all of them. And so our way of dealing with this is to come up with some other drugs that are effective against the resistant cell populations. And I'm going to speak briefly about a new drug we're working with, RSL3, which is a ferroptosis inhibitor. And we're also working with immunological modifiers. So looking at things that work at an immune level to hopefully address all of the tumor cells that are just beyond the distance. So try to stimulate some kind of an immune response on top of all of this. And so we've been working with some collaborators at Columbia. There's this drug that induces ferroptosis. And you may not have heard of this, but ferroptosis is a non-apoptotic cell death by the accumulation of these iron-dependent lethal lipid reactive oxygen species. And so what all of these very busy charts show is that there are drugs that block aspects of the ferroptosis pathway and induce an immunogenic cell death. So you have this non-apoptotic mechanism, and for whatever reason, it seems to work very effectively against the tumor cells that we've identified as being resistant to treatment. And here are some work. We have a system where we do what we call human slice cultures. You can take human tumor resected in the operating room, and you can make slices of it and keep it going in tissue culture for several days. It allows you to treat that tumor specimen and with a multiple of drugs, and then you can analyze it with single cell sequencing. So you can actually measure and look at what any drugs you're looking at, what it's doing with each of the individual cells, whether it's tumor cells, microglia, neurons, whatever. And basically what this picture shows down here is that the RSL3 is very effective against these resistant cells, and that when we can eliminate the effect of the ferroptosis by adding furostatin, which negates that. So it just sort of emphasizing the ferroptosis mechanism is what's responsible here. And when we looked at this in our animal model, we're able to show that the combination of topotecan and RSL3 worked synergistically to prolong survival. And with that, it gives us another drug to use with our convection delivery system. And so finally, we wanted to look at some immunological modifiers, and we looked at a number of different drugs. And as you probably know, glioblastoma is one of the most immunosuppressive environments. And so being able to deliver some kind of immunotherapy, immunological modifiers that can help move the needle away from this immunosuppression may have some benefit. We were looking at a number of different compounds, and there's a fair amount of work that's already been done, but we looked at something called STING, or stimulator of interferon genes agonist, and basically showed a modest survival advantage just with this convection enhanced delivery. This is all in our animal model. So we can improve survival with this immune modifier, and we can improve survival with the ferroptosis inhibitor, and we know we can improve survival with topotecan. So we're sort of coming up with this concept of a combination therapy, and that sort of leads to our conclusion here. Can we actually deliver a cure? If we optimize these delivery parameters, can we create an interchangeable platform for chronic delivery? And that's sort of what we're trying to do, is establish a platform, a strategy with our drug delivery system that could be adaptable for all kinds of drugs. And so for your residents and fellows out there, I realize that there's a path forward on all of this, and it's what keeps us motivated. I mean, I'm much later in my career, but this is still very exciting for us, and it's been a great privilege to work in brain tumors from the research and the clinical side. And there's really never been a better time to be doing this kind of research, and I'm grateful for this and the opportunity for it. And I show you this picture here. This is Harvey Cushing, and I'll go back to something that Ed Oldfield, who I mentioned earlier in the talk, he was one of my earliest mentors. And when I was, a junior resident or junior fellow at the NIH, and he was talking about neurosurgery and being famous, or what you hope to achieve. And he said, Harvey Cushing, most famous neurosurgeon that ever lived. Contributions he made, no neurosurgeon will ever come close to making the level of contributions that Harvey Cushing made. No neurosurgeon in the future will ever be able to overshadow Harvey Cushing. He said, but if you took 100 people off the street and asked them who Harvey Cushing was, he said, you might find one or two people who knew who he was. Those people are probably stamp collectors. And so he said, you better enjoy the journey, because that's what it's about. And so it's really been a great journey, and we're really excited about the next phase of this, where we're going to bring this back to the clinic. So we think that, we chose this provocative title, Can We Deliver a Cure? I don't know if a cure is possible, we're really just trying to move the needle and improve survival. But I think there's a formula that I think is starting to take place. And I think if we can truly overcome limitations of drug delivery, and we can use these combination therapies where we are where we're using a anti-proliferative target, where we're working with a metabolic inhibitor like RSL3 and an immune modifier, and you can add more drugs to this armamentarium if you like. The concept is that a multi-drug regimen delivered at high doses locally, avoiding systemic toxicity, may be able to help us improve survival for these patients, and hopefully with a better quality of life. So, sort of in conclusion here, can we deliver a cure? We are working with some companies to optimize the pumps and catheters that we use. We just took these off the shelf, commercially available. They're not ideal for these purposes, but we're working with some companies to modify them to make them more usable. Imaging is an important part of this. We're looking at different methods of imaging to monitor treatment response, but also volume of distribution. And we're looking at how to maximize our volume of distribution. All these trials, we're using one catheter, but probably makes sense to use more than one catheter so you get an even greater volume of distribution. And we're working on optimizing anti-tumor compounds. We have a very rigorous animal model group going in our laboratory, testing a lot of other different compounds, different combination therapies. And, one of the advantages of convection enhanced delivery is that there are new classes of anti-tumor compounds that would never be feasible with systemic delivery, because they're either would be metabolized in the liver, or they'd be too toxic, or they wouldn't cross the blood-brain barrier. So this is like things like antibodies or molecular biologics, siRNA, proteins, nanoparticles. All these things can now be repurposed for this. And we also can think differently about how chemotherapy works. So instead of chemotherapy that actually just kills tumor cells, we can think of drugs that we can deliver that can alter the microenvironment. So immunomodulatory drugs that actually try to reverse the immunosuppressive environment. So we're not just targeting tumor cells, we're targeting the whole tumor environment. And when you think about our ability now with chronic delivery of drugs, so if you have a pump, those pumps can stay in place indefinitely. And maybe the way to think about glioblastoma is the way we think about HIV and AIDS, and that is, patients with HIV are on these drug combinations for the rest of their life. They're not cured, but they keep the virus in check. And so maybe long-term chronic delivery, constant delivery of some combination of anti-tumor compounds just delivered on a chronic basis will turn glioblastoma, maybe if not curable, into some kind of manageable chronic disease. And finally, our treatment system, our drug catheter pump system, is actually treatment agnostic. We're looking at it for glioblastoma, but there's no reason that it can't be effective in other CNS diseases. When you think about every CNS disease, the treatment deficiencies stem from the fact that there are drug delivery limitations. All of these drugs, Parkinson's, Huntington's, Alzheimer's, epilepsy, all have limitations based on drug delivery. So it's possible that if we can show in glioblastoma the value of this delivery system, that it can be applicable to other types of systems. And I just want to finish by acknowledging our brain tumor laboratory. The individual in the center there, Peter Knoll, is our head of neuropathology, and he's been an outstanding collaborator. And these people that I work with, they work night and day. Glioblastoma is a relentless disease. That these tumors are growing. Glioblastoma doesn't take vacation. They don't take weekends off. And so you need a a group of people who are up to that challenge. And with that, I thank you for your attention, and happy to take questions.
Yeah, thanks very much. I know some of our oncologists, or a lot of our oncologists in both surgical and medical are on. Are there questions we can entertain or discussion? Dr. Vega, you were.
Yeah, thank you so much, Jeff, for this talk. It's really nice to get a historical overview and where you're going. I remember back in med school and even in residency doing CED type research myself. And, our targets were a little different. But, one thing that struck out to me is that, it's almost like in vogue at some point, and then it goes out of vogue, and then people start focusing on like focus ultrasound or something different, right? And I guess the thing is, why do you think, it hasn't really caught on too heavily, this idea of CED, just to start?
Well, I'll give you a couple of reasons. First of all of the early trials were done with drugs. Ed Oldfield's trials with the immunotoxins. There was TGF alpha immunotoxin. There was an EGFR. His initial one was transferrin. So those were very targeted therapies. And the reality is, with glioblastoma multiforme, it's a heterogeneous tumor. If all you're doing is targeting one receptor, you're never going to make an impact. I think it seems so obvious now, but back then I don't think we really realized. And I was involved in some of those early trials. I don't think we recognized that, but just the drug itself. So here we're in our trial here, we just used a single drug. We know that's not going to be sufficient. However, just with one drug as an anti-proliferative, so it's not a target, it's not targeted any single receptor, it targets proliferation, and it was very effective just by itself. So I think number one is the initial use of drugs that were too targeted for these heterogeneous tumors. The second thing was that we didn't have an implantable pump, so all you could do was one treatment, and pretty much every cancer treatment you can think of requires multiple dosing, multiple infusions, again, because you're affecting cell cycle kinetics. At any given time, there's only a fraction of tumor cells that are vulnerable to your treatment. So you have to keep cycling through you have to give your treatment through multiple tumor cycles in order to hit as many vulnerable tumor cells as possible. And then, I don't know if there are any neuro-oncologists on here right now, but I think, most of the brain tumor, most of the brain tumor world is dominated by neuro-oncologists who have, just very comfortable with the idea of systemic delivery. And think of all the clinical trials that have gone on for the last several decades, millions of dollars, lots of people, huge amounts of efforts with systemic chemotherapy, and none of it has really worked despite some very promising drugs. And I think we've mostly just proved that systemic delivery has significant limitations. To the extent that convection enhanced delivery requires a surgical procedure, it's sort of, as any neurosurgeon can do. This is a very simple procedure, but it takes it a little bit out of the hands of something that's very simple and easy for at an outpatient chemotherapy setting. But I think if our future clinical trials show that this is effective, to me, once these pumps are implanted, it would be great to have the neuro-oncology community embrace it, and probably would be more likely that they would be the ones managing the injections and infusions in the pump, so that they're the ones monitoring the patient, and an outpatient setting using the needle and syringe to replenish the pump at monthly intervals or whatever it's likely to be. So I think I think for those reasons it hadn't caught on, and we'll see where things go.
Yeah. Yeah, thank you. You know, I'll also just the second part of my question is that I totally agree with you on this. And I learned a little bit about this pump, which is new to me, and I congratulate you because I think that's a really big deal. And I guess one of the problems with chronic therapy in this systemic fashion is that the bone marrow really takes a hit, right? And I guess in this setting, if you control the volume, that might maybe help out in that respect, right? I mean, you could probably handle it.
Well, we measure systemic drug levels. They're undetectable during our treatment. You can't detect any drug in the systemic delivery. So I would expect no effect, no bone marrow suppression. I think that the levels are infinitesimal.
Yeah. So the question, I guess, is, you know, we unfortunately a lot of these clinical trials are done on the recurrent setting with a tumor that's already, you know, very aggressive. Any thought on like a, you know, first trial, if you will, or first pass?
Yeah,
On
no,
Mhm.
no, it's a great question. Yes, we've definitely thought of that. We based on all of our preliminary data, newly diagnosed tumors before radiation and standard chemotherapy will be much more effective with this approach. The group we're working with, recurrent glioblastoma, is an extremely high bar, and we'd expect much better success with newly diagnosed.
Yeah. Yeah. Thank you.
Jeff, have you had any experience with I mean, you try to increase the concentration of these agents and CSF delivery while you do the pump, or is that just completely ineffective, or we just don't know? You know, Adel Malik has this e-shunt, which is now evolving into a way to get drugs into the CSF in a way that's probably much more effective than the ventricle. So I just didn't know if you had sort of double pronged it, or even arterial is another way. But of course, I mean, all the old treatments with opening the blood-brain barrier, the brain barrier is disrupted at the tumor. So all the drug went to the the good brain, and we didn't know what went to the tumor. But
Yeah.
any other modalities of treatment that might be on the horizon?
Well, I think all of them are an advantage. Obviously, intra-arterial will increase the amount of drug that gets in, and I don't think CSF doesn't really penetrate the brain. You may get a little bit of penetration, but not nearly at the levels that you need. Also, focused ultrasound. I mean, if you look at the data, we're working with some collaborators here, and you know, maybe you can increase the drug levels anywhere from twofold to tenfold. But none of those come close to what we can do with convection, where it's 1,000-fold greater. So I think all of these systems are an improvement over just standard systemic chemotherapy. But you know, with convection, there's, you know, one or two levels of magnitude greater drug levels that are achievable.
Other comments, questions? If not, I will thank Dr. Bruce for his time and really fantastic talk. Jeff, as always, it's great to see you. Look forward to future interactions. New York is not that far away, so it's really, really great of you to do this. And if anyone needs Dr. Bruce's contact after this, I'm happy to provide it. But thank you very, very much.
My pleasure. It was great to see everyone. And yeah, obviously feel free to contact me if you have any other questions or concerns. And thanks again. Have a good day.
Thank you.
Thank you.
Bye now.